Hello and welcome to DocAT. In today's video, we're diving into the new topic of coronary artery disease. What it is, its pathophysiology, risk factors and causes, diagnosis and treatment. Let's break it down together. Coronary artery disease, also referred to as ischemic heart disease or atherosclerotic heart disease, is the most common type of heart disease and a leading cause of death worldwide. It occurs when the coronary arteries, responsible for supplying oxygen-rich blood to the heart, become narrowed or blocked. The primary underlying cause of coronary artery disease is atherosclerosis, a condition characterized by the accumulation of fatty plaques on the arterial walls. Over time, this can lead to reduced blood flow, impairing the heart's ability to function efficiently and potentially causing life-threatening complications. Coronary artery disease can manifest as angina, chest pain, shortness of breath, or even sudden cardiac events like heart attacks. Pathophysiology of coronary artery disease. Endothelial dysfunction. Damage to the endothelium, the innermost layer of the artery, is the initiating factor in coronary artery disease. This can result from hypertension, high blood pressure, smoking or exposure to toxins, high levels of LDL cholesterol and low HDL cholesterol, chronic inflammation, for example, due to diabetes or obesity, plaque formation, fatty substances, cholesterol, calcium, and cellular debris accumulate at the site of endothelial injury. Inflammatory cells like macrophages engulf LDL cholesterol, forming foam cells and fatty streaks. Over time, the plaque hardens due to calcium deposits, calcification, leading to arterial stiffness. Plaque progression. Plaques grow and progressively narrow the arterial lumen, reducing blood flow. Vulnerable plaques with thin fibrous caps can rupture, triggering clot formation, thrombosis. Ischemia and infarction. Partial occlusion results in ischemia, reduced blood supply, causing angina or other symptoms. Complete blockage of a coronary artery leads to myocardial infarction, heart attack, where cardiac tissue begins to die. Complications. Complete arterial blockage can cause myocardial infarction, heart attack. Chronic ischemia may result in heart failure or arrhythmias. Causes and risk factors. Non-modifiable risk factors. Age, sex, genetics. Age. Men, risk rises after 45 years. Women, risk increases after 55 years or post-menopause due to reduced estrogen levels, which have a protective effect on the cardiovascular system. Sex. Men are more likely to develop coronary artery disease earlier in life. After menopause, women's risk catches up due to hormonal changes. Genetics. Family history of premature coronary artery disease significantly increases the likelihood of developing the disease, particularly when combined with other risk factors. Modifiable risk factors. Dyslipidemia, hypertension, smoking, diabetes and insulin resistance, obesity, sedentary lifestyle, diet, alcohol consumption, and stress. Dyslipidemia. Elevated LDL cholesterol contributes to plaque formation. Low HDL cholesterol fails to remove cholesterol from the bloodstream effectively. Elevated triglycerides also play a role in accelerating atherosclerosis. Hypertension. Chronically high blood pressure exerts stress on arterial walls, leading to endothelial damage. Smoking. Cigarettes contain chemicals that promote oxidative stress and inflammation, accelerating plaque buildup. Smoking also increases blood clotting risk and reduces oxygen delivery to tissues. Diabetes and insulin resistance. High blood glucose damages arterial walls, promoting atherosclerosis. Obesity. Abdominal obesity is particularly dangerous due to its association with metabolic syndrome. Sedentary lifestyle. Lack of physical activity weakens cardiovascular function and contributes to obesity, diabetes, and dyslipidemia. Diet. Diets high in saturated fats, trans fats, sugar, and salt contribute to plaque buildup and hypertension. Alcohol consumption. Excessive alcohol raises blood pressure and triglycerides. Stress. Chronic stress increases cortisol and adrenaline levels, worsening hypertension and inflammation. Symptoms. Common symptoms. Angina pectoris. A classic symptom of coronary artery disease, characterized by chest pain or discomfort. May feel like pressure, squeezing, burning, or heaviness in the chest. Stable angina occurs predictably during exertion and is relieved by rest. Unstable angina occurs unpredictably, even at rest, and is a medical emergency. Shortness of breath, dyspnea, caused by reduced oxygen delivery to the heart and lungs during activity. Fatigue, a general sense of tiredness, particularly during physical exertion. Heart attack symptoms, intense, persistent chest pain or discomfort. Pain radiating to the left arm, neck, jaw, or back. Nausea, vomiting, cold sweats, dizziness, and a sense of impending doom. Silent ischemia. In some cases, coronary artery disease may present with no symptoms until complications like a heart attack occur. Diagnostic tests for coronary artery disease. Initial tests for chest pain. Electrocardiogram, ECG. Purpose: first-line diagnostic tool for any patient presenting with chest pain. Differentiates between ischemic and non-ischemic causes. Findings: normal ECG, often seen in stable angina. Ischemic changes: ST segment depression, greater than 1 mm in contiguous leads, indicates subendocardial ischemia. T-wave inversion, suggestive of ischemia or repolarization abnormality. ST segment elevation, indicates transmural ischemia, for example, STEMI. Q waves, evidence of a prior myocardial infarction, MI. Advantages: rapid, inexpensive, widely available. Essential for triaging patients into stable angina, unstable angina, and STEMI or STEMI categories. Cardiac enzymes, CABG and troponins. Purpose: identify myocardial injury or infarction. Procedure: blood samples are taken serially at presentation and after 3 to 6 hours to assess for changes. Findings: stable angina, normal troponin and CABG levels. Acute MI, elevated troponins are highly sensitive and specific for myocardial necrosis. Interpretation of troponins: rise and or fall in values with clinical evidence of ischemia confirms an MI. Persistent elevation may suggest ongoing injury, for example, myocarditis, renal failure. Advantages: provides a biochemical marker for acute coronary syndromes. Chest X-ray. Purpose: rule out non-cardiac causes of chest pain and assess for complications. Indications: suspected aortic dissection, esophageal perforation, pulmonary embolism, or pneumonia. Findings: aortic dissection, widened mediastinum or abnormal aortic contour. Esophageal perforation, mediastinal air or pleural effusion. Pulmonary embolism, pleural effusion or wedge-shaped infarction, Hampton's hump. Pneumonia, lung consolidation or air bronchograms. Stress testing, exercise or pharmacologic. Purpose: detect inducible myocardial ischemia and stratify the risk of coronary artery disease. Types of stress testing. Exercise stress test. Procedure: patient exercises on a treadmill or stationary bike while heart rate, blood pressure, and ECG are monitored. Target heart rate: 85% of maximum predicted heart rate, 220 - age. Findings: positive test, ST segment depression greater than 1 mm during exercise, angina symptoms, or arrhythmias. Helps identify ischemic thresholds and functional capacity. Limitations: requires physical ability to exercise. Pharmacologic stress test. Indications: for patients unable to perform adequate physical exercise, for example, due to arthritis, deconditioning. Agents used. Dobutamine stress echo, increases heart rate and contractility to mimic exercise. Dipyridamole or adenosine thallium scan. It causes coronary vasodilation, revealing perfusion differences. Findings: wall motion abnormalities on echocardiography, ischemia. Perfusion defects on nuclear imaging. Thallium scan, nuclear imaging. Purpose: evaluate myocardial perfusion to detect ischemia or infarction. Procedure: radioactive tracer, for example, thallium-201 or technetium, is injected. Images are taken at rest and after stress using a gamma camera. Findings: reversible defect, reduced tracer uptake during stress but normal at rest indicates ischemia. Fixed defect, persistent tracer deficit indicates infarcted myocardium. Advantages: high sensitivity and specificity for coronary artery disease. can assess the viability of myocardium for revascularization. Preparation for stress testing. Medications like beta blockers, calcium channel blockers, and nitrates should be withheld for 48 hours before testing to avoid false negative results. Avoid caffeine and heavy meals prior to testing. Advanced imaging. Coronary angiography, invasive. Purpose, gold standard for coronary artery disease diagnosis. Provides direct visualization of coronary arteries. Procedure. A catheter is inserted via femoral or radial artery. Contrast dye is injected, and X-rays are taken to visualize arterial narrowing. Findings. Identifies stenosis severity, location, and coronary anatomy. Indications. Patients with high suspicion of coronary artery disease and inconclusive non-invasive tests. Planning for revascularization, PCI or CABG. CT coronary angiogram. Purpose, a non-invasive alternative for visualizing coronary arteries. Procedure, uses contrast-enhanced CT to detect coronary stenosis or plaque burden. Findings, significant stenosis, greater than 70%, or coronary calcifications. Advantages, useful for low to intermediate risk patients. Additional diagnostic tools. Holter monitoring. Purpose, continuous ECG monitoring to detect transient arrhythmias or ischemic episodes. Procedure, patient wears a portable device for 24 to 48 hours. Indications, evaluation of symptoms like palpitations, syncope, or intermittent chest pain. Suspected silent ischemia or arrhythmias, for example, atrial fibrillation PVCs. Findings, ST segment changes or arrhythmias during normal activities. Echocardiography. Purpose, assess cardiac structure and function. Types, resting echo. Identifies wall motion abnormalities or prior myocardial infarction. Stress echo. Assesses ischemia by detecting wall motion changes during stress. Cardiac MRI. Purpose, non-invasive imaging for myocardial perfusion, viability, and fibrosis. Indications, evaluation of scarring, viability, or when other imaging tests are inconclusive. Coronary calcium scoring, CT. Purpose, non-invasive assessment of coronary calcification for risk stratification in asymptomatic patients. Utility, helps predict future coronary artery disease risk. Not suitable for diagnosing symptomatic coronary artery disease. Treatment of coronary artery disease. Effective treatment of coronary artery disease focuses on relieving symptoms, slowing disease progression, and preventing complications like heart attacks or heart failure. Treatment is typically tailored to the individual's condition, risk factors, and disease severity, and involves a combination of lifestyle modifications, pharmacological therapies, and surgical or procedural interventions. 1. Lifestyle modifications. These are the cornerstone of coronary artery disease management and can significantly reduce disease progression. Dietary changes. Adopt a heart-healthy diet. Increase consumption of fresh fruits, vegetables, whole grains, lean proteins, for example, fish, chicken, legumes, and nuts. Choose healthy fats, monounsaturated and polyunsaturated fats, like olive oil and fish oil, over saturated and trans fats. Avoid processed and fried foods, sugary snacks, and high-sodium packaged foods. Specific diet approaches. Mediterranean diet focuses on olive oil, fish, nuts, and plant-based foods. DASH diet, designed to reduce blood pressure, emphasizing low sodium, high potassium, and nutrient-rich foods. Exercise. Engage in aerobic activities, for example, brisk walking, jogging, cycling, swimming, for at least 150 minutes per week. Include resistance training 2 to 3 times per week to improve muscle strength and metabolic health. Avoid prolonged sedentary behavior, incorporating movement into daily routines. Weight management. Aim for a healthy body mass index, BMI, 18.5 to 24.9, and reduce abdominal obesity. Waist circumference less than 102 centimeters for men, less than 88 centimeters for women. Modest weight loss, 5 to 10% of body weight, can improve lipid profiles, blood pressure, and insulin sensitivity. Smoking cessation. Quitting smoking is critical, as it reduces coronary artery disease risk significantly within 1 year and continues to decrease over time. Support options include nicotine replacement therapy, patches, gum, prescription medications, for example, varenicline or bupropion, and behavioral counseling. Alcohol consumption. Limit alcohol intake to moderate levels. Up to 1 drink per day for women and up to 2 drinks per day for men. Avoid excessive consumption, which increases blood pressure and triglycerides. Stress management. Adopt techniques like mindfulness, yoga, deep breathing exercises, or cognitive behavioral therapy to reduce stress and its impact on heart health. Managing stress also helps in maintaining healthy blood pressure and avoiding unhealthy coping mechanisms like overeating or smoking. Pharmacological drug treatments. Medications play a vital role in controlling symptoms, reducing plaque buildup, and preventing complications. Commonly prescribed medications include anti-anginal medications. 1. Nitroglycerin, short-acting nitrates, relieves acute chest pain by dilating coronary arteries and improving blood flow. Available as sublingual tablets, sprays, or patches for immediate relief. 2. Long-acting nitrates, for example, isosorbide mononitrate, used for chronic management of angina symptoms. Cholesterol-lowering medications. Statins, lower LDL cholesterol and stabilize plaques, reducing the risk of heart attack, for example, atorvastatin, rosuvastatin. May have additional anti-inflammatory properties. Proprotein convertase subtilisin/quercetin type 9, PCSK9, inhibitors. Injectable drugs, for example, alirocumab, evolocumab, for patients with very high LDL or familial hypercholesterolemia. Ezetimibe reduces cholesterol absorption in the intestines, often used alongside statins. Antiplatelet therapy. Aspirin, low-dose aspirin, 75 to 325 milligrams daily, prevents clot formation by inhibiting platelet aggregation. P2Y12 inhibitors. Clopidogrel, ticagrelor, or prasugrel are used in combination with aspirin, particularly after stent placement, dual antiplatelet therapy. Antihypertensive medications. ACE inhibitors, for example, lisinopril, ramipril, lower blood pressure, reduce strain on the heart, and improve endothelial function. Angiotensin receptor blockers, ARBs, for example, losartan, valsartan, used as alternatives to ACE inhibitors. Beta blockers, for example, metoprolol, bisoprolol, decrease heart rate and myocardial oxygen demand, reducing angina and preventing recurrent heart attacks. Calcium channel blockers, for example, amlodipine, diltiazem, relax blood vessels and reduce chest pain. Diabetes management. Sodium glucose cotransporter 2 inhibitors, lower blood sugar and provide cardiovascular benefits, for example, empagliflozin. Glucagon-like peptide 1 receptor agonists, for example, liraglutide, improve blood sugar control and may reduce cardiovascular risk. Other medications. Ranolazine, used as a second-line therapy for chronic angina. Anticoagulants, for example, warfarin, rivaroxaban, for patients at high risk of clotting. Interventional and surgical treatments. These treatments are recommended when lifestyle changes and medications fail to control symptoms or when significant blockages are present. Percutaneous coronary intervention, PCI. Angioplasty. A catheter with a balloon is inserted into the blocked artery. The balloon is inflated to widen the artery. Stent placement. A stent mesh-like tube is placed to keep the artery open permanently. Types of stents. Bare metal stents. Drug-eluting stents. Release medication to prevent restenosis, re-narrowing. Coronary artery bypass grafting, CABG. A surgical procedure that reroutes blood flow around blocked arteries using grafts taken from other parts of the body, for example, saphenous vein, internal mammary artery. Typically recommended for patients with multiple blocked arteries or severe blockages in critical locations. Enhanced external counterpulsation, ECP. A non-invasive procedure for patients with refractory angina. Inflatable cuffs are placed on the legs to increase blood flow to the heart during diastole. Atherectomy. Removal of plaque from the artery using a rotating device. Emerging and advanced treatments. Gene therapy. Investigational treatments aimed at promoting new blood vessel growth in the heart, angiogenesis. Stem cell therapy. Research focuses on regenerating damaged heart tissue using stem cells. Coronary sinus reducer. A small device implanted to reduce angina by increasing pressure in the coronary sinus and improving microvascular circulation. Cardiac rehabilitation. A supervised program involving exercise training, nutritional counseling, risk factor modification, and psychological support. Aims to restore physical fitness, improve quality of life, and reduce the risk of future cardiac events. Monitoring and follow-up. Regular follow-ups with a cardiologist ensure treatment effectiveness. Routine monitoring may include blood tests for lipid profiles, glucose, and markers of inflammation. Stress testing or imaging studies to assess heart function. Medication adjustments based on side effects or disease progression. Thanks for watching Doc AT. If you found this video helpful, please like, share, and subscribe for more medical insights. Drop any questions or comments below. We'd love to hear from you. See you in the next video.